Hello, this is David. And continuing on with parameters that are followed in pregnancy to monitor complications of pregnancy, such as intrauterine growth restriction. Let's now, this is the second clip. In the first clip, we spoke about sonographic parameters of arterial flow within the maternal circulation and in the fetal circulation via the fetal umbilical artery. For the purpose of review, let's now just turn our attention to a brief review of the fetal circulation. So, blood is used predominantly by the fetal head and brain, and the deoxygenated blood returns predominantly via the superior vena cava to the fetal right atrium. From there, the blood that comes from the fetal right atrium preferentially drains directly through the tricuspid valve into the fetal right ventricle, and then goes out the fetal outflow, right-sided outflow tract. Because at this point, the pulmonary arteries are essentially closed because of very high pressures within the pulmonary circulation, the blood goes into the ductus arteriosus. And now we could turn our attention to the diagram. So it goes out the right ventricular outflow tract, into the ductus, and into the descending aorta. And even though that's arterial blood, it's painted in blue here because it's quite deoxygenated. And the blood flow in the descending aorta bifurcates at the level of the iliacs and goes into the internal iliacs, and from there to the umbilical arteries, which are actually paired structures, shown here in blue because they carry deoxygenated blood to the placenta. The blood goes into the placenta, into the capillaries of the placenta, exchanges with the maternal blood, and then comes back via a single umbilical vein that empties into the fetal inferior vena cava via a structure called the ductus venosus. So the venous return from the placenta goes through this ductus venosus. It's a specialized structure that pierces the fetal liver and enters the inferior vena cava just at essentially the level of the hepatic vein. The oxygenated blood then goes from the inferior vena cava into the right atrium, and that stream largely goes through the foramen ovale into the left atrium, down into the left ventricle via the mitral valve, and the left ventricular stream preferentially goes to supply the head and neck, and especially the head and brain region, with oxygenated blood. So in terms of parameters that could be followed in the fetal arterial circulation, we spoke about the umbilical arterial flow. The other thing that could be followed and that is followed, are the fetal middle cerebral arteries. And that's important. And you'll hear things like middle cerebral artery peak flows and also middle cerebral artery redistribution as parameters to follow fetal health. But we won't discuss that in detail here. We won't really get into it. And the reason is because my main concern is to encourage people to use mathematical models of anatomical placental growth to try to correlate that with parameters that we know. And one parameter that we have information and increasing information on are ultrasound Dopplers of flow parameters in the fetal circulation. And if we look at those aspects of the fetal circulation that supply the placenta and try to see how changes in those relate to anatomical variances in the placenta, we might come to a better understanding of placental pathological states. And that's what I want to sort of encourage people to do. So let's focus on those aspects of the fetal circulation that pertain to supply and return from the placenta. So the supply to the placenta is represented by flow in the umbilical arteries. Incidentally, the sonographer could look at umbilical artery flow in the umbilicus or in the fetus itself next to the fetal bladder. And so when the sonographer is counting the number of fetal umbilical arteries, they often count it in both locations to see if there's two arteries, both at the level of the bladder as well as at the level of the umbilical cord. So that's the fetal arterial circulation. The other thing that could be followed is the fetal venous circulation. And the portion of the fetal venous circulation that follows is the flow within the ductus venosus. And one could look at the flow waveforms within the ductus venosus. And the student of medicine is somewhat familiar with venous waveforms because we're taught to take jugular venous pressures within patients, and there's an A wave and an X descent, and I won't get into it in much detail, but to my understanding, that's really a pressure curve. And what we're looking, and especially if you're doing invasive monitoring in the ICU, you may be looking at a pressure curve. But what the sonographer is looking here is at a flow curve, but it's not too dissimilar. And they're looking at flow curve, the flow within the ductus venosus. But you could imagine that if the fetal right ventricle is seeing such high pressures because of, within the umbilical arterial circulation, then those high pressures within the fetal right ventricle will ultimately translate to high pressures within the fetal right atrium. And it could turn out that there may actually be phases within the fetal cardiac cycle where blood isn't going toward the right atrium. Because if the pressures and resistances are high enough, then during a portion of the cardiac cycle, the pressures might build such that blood actually flows away from the fetal right atrium. And that would be a rather late event. And that is what's referred to, this is a rather crude description, but this is my understanding of it, as A-wave reversal. So without getting into further detail, one of the parameters that the maternal fetal medicine or obstetrician is looking for is A-wave reversal in the ductus venosus of the fetus. Now, you can imagine that once one sees that, that's a relatively late progressive event, because that suggests that you've already had increased pressures and increased resistance within the arterial circulation that sort of back translated into increased right ventricular pressures and ultimately right atrial pressures, and now reversal of flow in the venous circulation. And so that's a late event. And so it's not surprising then that if you see A-wave reversal, that suggests that the fetus is at quite considerable risk. And that'll often necessitate an urgent operative delivery or an urgent induction. Because it's said that if one sees A-wave reversal in the ductus venosus, death could occur unexpectedly. So, just to recapitulate, what we spoke about in these last two videos are things that the obstetrician can monitor to look at the health of a pregnancy. And we started off by looking at factors in the previous clip in the maternal circulation, including the uterine artery Dopplers. And we mentioned that people were looking at systolic to diastolic ratios, pulsatility indexes, and resistance, and ultimately in the second trimester this phenomenon called notching. And then we also mentioned that one could then look at problems in the fetal circulation, and what one could look at is first the umbilical arteries. People could also look at the fetal middle cerebral artery, which isn't a point of focus because it doesn't directly pertain to placental flow, and they could also look at venous phase of the fetal circulatory cycle by looking at flow within the ductus venosus. And with that, I'm going to end this installment. And in the next installment, we'll start to contemplate what's the series of pathological progression of abnormality that one gets in instances of severe IUGR, and how these can be potentially correlated with histological anatomical abnormalities of the placenta, which is what I consider the holy grail that we should be working towards. So thank you very much.